Buenos días a todos. Good morning, everyone. It's a real pleasure and real honor to be here this morning. Thank you very much to the organizers of CannaTech and to all the people and all of you that are here today. I don't know if you prefer if I speak in Spanish or in English. I think Spanish, English? Let's vote. I will try to do it in English then, and maybe I will jump in Spanish, several things that I would like to express in Spanish, maybe. For those who doesn't know me, as Lorena introduced me, I'm a physician. I am proud Colombian. I'm from Colombia, and I am an anesthesiologist. I went to Mexico City. I was trained in Mexico as an anesthesiologist, and I'm a pain and palliative care physician also. Then I moved to Canada. I lived in Montreal. I went to McGill University. I was there for several years and working at a specialized cannabis clinic, which is called Santé Cannabis, one of the leading specialized cannabis clinics in Canada, and specifically in the province of Quebec, where we've seen thousands of patients with several conditions, among, for instance, chronic pain, cancer, autism, epilepsy, Crohn's disease, and many others that Dr. Dor was already commenting before. But obviously, chronic pain is the main condition and the main chief complaint that make people come and seek for a possibility with medical cannabis. And currently, I'm the medical director at Khiron, and we're doing several very exciting things for Latin America. So let's start. Before starting, as I was saying, some of my disclosures. I'm a co-investigator right now for 3 clinical trials that are being supported by Tetra Biopharma. And I'm the research associate director at Santé Cannabis and the medical director at Khiron. However, today I'm not going to talk about any of these. I'm going to talk about explicitly evidence-based rather than recommendations of us based on specific products. So what are we going to talk about? First of all, I'm going to give you a little background about chronic pain. I don't know how many of you here know about chronic pain. Most of us know someone, at least, with chronic pain, suffering from chronic pain. Then I'm going to talk about what is the evidence so far regarding chronic pain, and then I'm going to move forward to talk about future directions. Where are we going right now in terms of research? So, chronic pain. How many of you here suffer from chronic pain? You see, it's very frequent that we see these here. By definition, chronic pain, according to the IASP, which is the International Association for the Study of Pain, says that a person that is suffering with pain for more than 3 months, by definition, that is called chronic pain. And unfortunately, currently, this is an enormous global public health problem where 1 in every 10 adults are diagnosed with chronic pain. Of course, this is very unfortunate and is very expensive also. We're talking about $635 billion per year only in the United States are being spent for patients that are suffering from chronic pain. Now, when we talk about chronic pain, it's not only pain, because patients with chronic pain are suffering from anxiety, depression, what else? They're not sleeping well, insomnia because of pain, and living with someone with pain is not easy either. Being the family of these patients with chronic pain is not easy either. So if I show you some of the information that we have, sorry, this is moving too fast. Some of the information that we have so far, we know that around more than 30% of the patients that are suffering from chronic pain are reporting moderate to severe pain when they are asked about their intensity. And it's quite challenging and quite frustrating sometimes for us as pain physicians, and as well as palliative care physicians when we have to treat chronic cancer pain. Why? Because we are finding not very good solutions to help our patients to control their pain. And when we talk about management of pain, it's not only one thing. Chronic pain is a very complex condition where we need what we call a multimodal, or many different type of treatments to help patients with chronic pain. Chronic pain, as many other chronic conditions, we cannot cure pain. We can control pain. And it's the same as when we have someone with diabetes or hypertension. What happens to the patient when the patient has diabetes and they don't take their insulin? Or what happens to the patient when they have high blood pressure and they don't take their pill for the blood pressure? Well, the blood pressure is not going to get controlled. And if a patient comes to the office asking or seeking, hello doctor, I'm here because I want to get cured of my diabetes, well, I would love to tell you, yes, you will get cured, but it's not real. This is a chronic condition, and we can control your sugar levels, we can control your blood pressure, but we cannot cure you. We can control with some strategies or pharmacological treatments or non-pharmacological treatments. Same for chronic pain. When we talk about chronic pain, we cannot cure pain. We can control that pain with several or different strategies, and that's what we call multimodal analgesia. We have pharmacological treatments and non-pharmacological treatments. When we talk about pharmacological treatments for chronic pain, we're talking about opioids, NSAIDs, which are the non-steroidal anti-inflammatory drugs. We're talking about sometimes anti-epileptics. We know that pregabalin or, for instance, gabapentin, which are anti-epileptics, are very helpful for chronic pain in terms of neuropathic pain conditions. Also, when we talk about antidepressants, sometimes we give patients with chronic pain antidepressants, not because they're depressed, but because we know that antidepressants at low doses can also help to control neuropathic pain. So why am I explaining all of this? I'm explaining this because when we talk about different modalities or different options or tools to help our patient to control their pain, well, obviously cannabis or cannabinoids is in our picture here. And we say, okay, we have another tool to bring it up to our toolbox to help our patient to control this chronic pain condition. I'm going to elaborate later a little bit more about this. So, what is the situation with cannabis right now? What we know and what we don't know about medical cannabis? Well, right now, it's important that we know that there's some people saying that cannabis could be a promising and effective therapy as an adjunct or as a substitute for symptom management. But here we have to be very careful because cannabis, yes, could be an adjunct or an adjuvant to what the patient is taking. It's a complement to what the patient is taking to control their pain, but it's not going to substitute everything else. And that's something important to consider because patients are coming to our office seeking for cannabis treatments because they want to get rid of all the other medications. Of course, I would love to get rid of opioids. I would love to get rid of NSAIDs because NSAIDs also, they produce renal failure, gastrointestinal bleeding, myocardial infarcts, and so on and so on. Of course, I would like to get rid of all of these medications and all of these side effects. But sometimes cannabis is not going to replace all of them. Sometimes, and what I tell to my patients is we could have two possibilities here. One possibility is that we start with cannabis, and cannabis will be a great team together with the other medications. They'll do a very good team, and they will work together, cannabis and the other medications that the patient is taking. Or sometimes we have patients where we can start tapering down their opioids, tapering down their NSAIDs, pregabalin, or any other medications that they're taking. So it's important that I emphasize on this because cannabis is an adjunct to the symptom management, in this case, chronic pain. Now, something that, of course, we're always repeating, we are still very limited in terms of evidence-based. We, as doctors, what we do is always based in what is published in the medical literature. What is the evidence for this? What is the evidence for that? For cannabis, we're still, let's say, we have a lot of gaps to fill in right now. We're very limited right now by lack of good quality evidence, and that's what we're trying to do right now. Filling in those gaps. When we say there's a lack of evidence, doesn't mean that there's a lack of efficacy of a product. So that means that we need to continue building up this evidence. Now, what are the three main challenges when we talk about the use of medical cannabis in the clinical practice? Well, there are many, but these are the ones I've identified as the most important. First one, as I was saying, the gaps in research, which we're trying to fill in right now, is not easy, and that's what I'm going to talk about later, about what are the areas of debate when we talk about the research. Second of all, we have what we call this important social stigma. What about the social stigma? Well, it's huge. Even in Canada, where I've been working, Quebec is one of the most conservative provinces in Canada. And I have many patients. Most of them are old ladies, 70, 80-year-old ladies with osteoarthritis that are saying, oh, I'm here not because I want to be here. It's because my son forced me to come here because they told me that cannabis could be a possibility for my chronic pain, but I don't want to be an addict. I never did drugs in my life, and please, I just don't want to smoke. I've never smoked in my life. So there's a lot of stigma there, and there's a lot of myths versus realities that we need to clarify to our patients. But what's happening is that here is my third challenge. We're having a lot of limitations in medical education right now. And some of these was mentioned before early this morning, where we are not being taught, they're not teaching us in med school or during our specialty courses about cannabis. And I always ask, when I'm giving a talk to the audience, normally healthcare practitioners, I will ask them, how many of you received a class about the endocannabinoid system? How many of you knew about the CB1, CB2 receptors, anandamide, 2-AG? How many of you received classes about THC, CBD, terpene, CBN? No one. Why? Why we didn't receive this type of information? And most of the people in the audience, they would say, I'm too old and this is new, this is the hot topic right now. No, it's not new. We're talking about the endocannabinoid system since the 1960s. Since the 1970s, THC was isolated by Professor Meshulam in Israel, and we're talking about using cannabis since 3000 before Christ. So it's not new, and it's very, frustrating that we're receiving this kind of information during our education. So this goes ahead with, nowadays, if you go to these two surveys that were done, one for oncologists in the United States, 237 oncologists were asked, how comfortable do you feel having a conversation with your patient? How knowledgeable do you feel to have a conversation about medical cannabis with your patient? Less than 30% are feeling comfortable having this conversation. Same here in Australia. 600 GPs, general physicians, were asked about the same thing. How comfortable do you feel about discussing medical cannabis with my patients? And here is even worse. More than 50% are feeling uncomfortable to have this conversation with these patients. Now, what are we doing in Latin America? In Colombia, I can tell you that it was very exciting. 2 weeks ago, we had this very exciting course with Khiron where we were training a specific group of doctors. Nowadays, we know that it's very important to do massive talks and seminars and symposiums about medical cannabis, which is great to create awareness. Yeah, but when we want to train doctors about prescribing medical cannabis, we cannot give it in a huge room. It has to be small groups, very face-to-face, one-to-one, This type of courses is what we're starting to do right now in Colombia, and we had the first one 2 weeks ago, which was great. It was a great experience with doctors in Colombia, the support of the medical associations also in Colombia. At Khiron, we have the endorsement of the Colombian Association of Pain, Palliative Care, Internal Medicine, and Neurology. And we're starting also to work with the Association of Geriatrics and Sleep Disorders, which is great because we have also this support from all these doctors, around 3,000 doctors in Colombia supporting us with all these projects. So we asked these 7 to 10 doctors that came to this very, very customized course about how knowledgeable they felt about medical cannabis. And here is the same. Most of them were feeling poor or satisfactory, and when we asked about what is your interest in learning more, well, yes, there is a lot of interest in learning more about medical cannabis. Now, there's a vast interest in a number of topics. For instance, when we talk about chronic pain, you see how the gap is huge. 4.8 of the desired knowledge versus 2.3 of the current knowledge. So there's a huge gap between the current knowledge of the doctor and the desired knowledge of this doctor. What do we have right now in terms of evidence for cannabis in chronic pain? This has been an explosion in the literature. Every time we go to PubMed, which is one of the databases that we use as physicians to look for several articles, it's an explosion. Every day you find something different. But because there's a growing interest in the use of cannabinoids for the treatment of chronic pain, cancer and non-cancer pain, we've seen, for instance, in Canada, where this program in Canada started back in 2001, and since 2014, it was a bit better. And after that, we've seen that the majority of patients are seeking for cannabis to control their chronic pain symptoms. And the same in the US. Most commonly, the cited reason for accessing medicinal cannabinoid products in the US is for chronic pain. So it's important to understand what is going on in terms of the evidence. Is it working? Is it not? Is it effective? Is it safe? Is it not? We don't know yet. What we know is that there's several systematic reviews. Systematic reviews are the most high quality evidence that we have. Systematic reviews and meta-analysis are what we're always looking for when we're looking for evidence. And if you go and check some of these, we have the Whiting study, we have the National Academies, we have the Health Canadas, and all of them, unfortunately, are the conclusions are very different. We have a conflict in the conclusions, and we have to be very careful with the interpretation of the evidence. In most cases, what we found is that inhaled cannabis, is effective most of the time for neuropathic pain, which is important to differentiate because we have different types of pain. Pain, as I was saying, is a complex thing. We have nociceptive, neuropathic, peripheral neuropathic, central neuropathic. We have a whole classification about chronic pain, and what we found is that exclusively for neuropathic pain is the vast majority of studies talking about the efficacy. Now, this is a very recent article that was published in terms of analyzing or summarizing the evidence in terms of chronic non-cancer pain, which is different to chronic cancer pain, of course. And here, as you can see, these are the several different studies that have been done. And you see how different the conclusions are. Some of them are saying there's moderate quality evidence. Some of them are saying there is substantial evidence, might be effective, limited evidence, any benefit of cannabinoids outweighed by harms, and then the last one saying it's unlikely that cannabinoids are highly effective medicines for chronic non-cancer pain. So what do we do if there's so many things going on right out there? What do we need to do is we need to continue filling in the gaps. These systematic reviews are analyzing 1, 2, 3 randomized control trials. We need to continue doing more randomized control trials. Stop doing systematic reviews and start working more towards these randomized control trials. In terms of cancer pain, well, the story is a bit different compared to non-cancer pain. In terms of cancer pain, we have the classic study of Johnson study, which was published in 2010, where they were testing nabiximols or Sativex to see if it was effective for chronic pain. There was analgesia, but there were many side effects. When you increase the dose of Sativex, well, you will have more side effects, of course. We decided to do, in Canada, I did this retrospective analysis of a specific cancer pain population with the group I work with in Canada. And we found that when we decided to see how patients were doing at baseline and 3 months after cannabis treatment. We were doing a questionnaire that is very usual to use in the pain world, which is the BPI, and the average pain after 3 months of treatment with cannabis was significantly lower when we gave this treatment. The majority of patients were receiving THC CBD 1-to-1 ratio, and the most common side effects were drowsiness, dizziness, and dry mouth. So this is I will finish now because time's up. This is another article I just published with the team I work with in Canada, which is the use of cannabis in palliative care. What we try to do here is current challenges and practical recommendations. It's very important to mitigate the expectations of our patients when we have the patient in front of us, to explain what is going to happen with their treatment with cannabis. Cannabis is not the miracle drug. Cannabis is a complement to the treatment that the patient is receiving. Cannabis is not for everyone. There's some patients that they will not find it efficient. There are some patients that they will find it fantastic. So it's a very customized, very individualized treatment, and we have to be very careful with that. So I think I will just finish with my take-home messages, if I may. These are the areas of debate that we have right now: the ideal sample size, long-term follow-up. We don't have that. We don't know THC, CBD. Is it better THC? Is it better CBD for pain? We don't know yet. We're trying to find out what is the titration regimen we should use. And obviously the regulation is always a challenge for us when we're trying to do research with cannabis, because according to each country, we have to adapt to these regulations, and that's a huge limitation. Where if you go to clinicaltrials.gov, these are the future directions. You type in cannabis and chronic pain, you'll find several, around 26 studies right now for cannabis and chronic pain. One of those is the one I'm doing right now in Canada, when we're trying to do safety and efficacy of medical cannabis oil in the treatment of chronic pain. And what we're trying to do is dividing different groups. Is it neuropathic pain? Is it nociceptive pain? Is it mixed pain? And is it THC? Is it CBD? So we're having also a placebo arm, and that's part of the job we're trying to do there in Canada. This is what we have to do for Latin America. We need to do best clinical practice, and we need to engage the countries and the regulations in order to help us to fill in those gaps, because we need research with local patients and local products. Because Canada and Israel are different to Latin American patients. We have seen that with other medications. With opioids, for instance, morphine doses were extremely high versus the morphine doses that we use in Colombia, for instance. So we have to be very careful with these, and that's why we need to do local research. Take-home messages: medical cannabis still limited by lack of good quality evidence that approves its use in chronic pain. Most trials support therapeutic benefit of inhaled cannabis for chronic neuropathic pain. The use of medical cannabis as an adjuvant to conventional treatment for symptom control, as I was saying, is not the miracle drug, is a substitute, and we need to mitigate patients' expectations in order to avoid frustration also of patients and frustration of as physicians also. And we need to encourage education and offer opportunities that support research development in this field. Thank you very much to all of you. It was a pleasure to be here. I'll be happy to share with you later on. Thank you.